The pelvis connects the upper body to the lower body. In African diaspora cultures, it is revered for its life-giving force. So when you see those beautiful hips and pelvic girdle moving, just know they are embodied African diaspora health practices, keeping the pelvic area healthy and ready to receive and deliver the next generation. NSU welcomes you to the Black Maternal and Child Health Conference. Ashe. Please welcome our Provost, Dr. DoVeanna Fulton.
Good morning, everyone. That's a way to start a conference, right? Well, I am so delighted with the opportunity and privilege as Provost of Norfolk State University to welcome you to the 2025 Black Maternal Child Health Conference. And I want to thank each of you for joining us, and in particular, Dr. Hammond, Executive Vice President of the Virginia Health Sciences. We are incredibly proud to host this vital gathering with the theme, Standing to Protect Black Maternity, Breaking Barriers, and Empowering Change. I'm gonna stand back a little bit. Oh, is it on? Yeah. No? This theme powerfully reflects both the urgency and the promise of the work being done across the country and here in our community to protect Black mothers and their children, and to bring build a healthcare system rooted in equity, dignity, and justice. When I first saw the theme, I thought about Sly and the Family Stone's song, Stand. Stand, in the end, you'll still be you. One that's done all the things you set out to do. Stand, there's a cross for you to bear, things to go through if you're going anywhere. Stand for the things you know are right. It's the truth that the truth makes them so uptight. Stand, all the things you want are real. You have to complete, and there is no deal. This conference, sponsored by the Consortium for Infant and Child Health, Black Maternal Health Equity Action Alliance, and hosted by NSU's Center of Excellence in Minority Health Disparities and the NSU Health and Wellness Initiative for Women, is a shining example of what can be achieved when academic institutions, healthcare professionals, researchers, and community partners unite around a common mission. At Norfolk State University, we're deeply committed to confronting health disparities, especially those that impact Black women and families. The data is undeniable, but it is not immovable. Black women in the United States are far more likely to face life-threatening complications during pregnancy and childbirth, and this reality is not a reflection of biology, but long-standing structural inequities in access, care, and representation. Yet there is power in truth, and there is power in community. Today, we gather to speak truth, to share knowledge, and to strengthen the collective voice advocating for systemic change. Whether you are a student, a researcher, a healthcare provider, an advocate, policymaker, a parent, or a child, your presence here matters. Your voice matters, and your work is helping to reshape the future of maternal and child health. I want to express my deep appreciation to our partners at CINCH, as well as the dedicated faculty, staff, and leaders of the NSU Center of Excellence on Minority Health Disparities and the NSU Health and Wellness Initiative for Women, in particular, Dr. Cynthia Burwell, Dr. Sheila Ward, and all of our faculty in the School of Education, the Department of Nursing and Allied Health, and the Center for Public Health Initiatives. Your leadership continues to elevate the role of historically Black institutions in public health innovation and community care. So as we move through this conference, let us challenge assumptions, uplift each other's efforts, and reimagine a system that truly protects and honors Black motherhood. Together, we can and will break barriers and empower lasting change. So welcome to Norfolk State University. We are honored to be part of this powerful movement with you. Thank you.
Thank you so much, Dr. Fulton. Get all of our crew up. I'm gonna stand over here and hopefully the people online can hear a little bit better. They're having some trouble with our virtual people. We have well over 100 people joining us across the day online. So I'm Amy Paulson. I'm the director for CINCH, and I'm a faculty member at the medical school at Altman University. And I want to introduce our two co-chairs for our Black Maternal Health Equity Action Alliance, Takemia Cornegy-Hawks and Benita Thompson. And I'd love for them to just say welcome and good morning. They have been instrumental in this conference is actually only one small part of what we do. So if you look in your packet, there's a link or a QR code somewhere to our BMHEAA website that tells you about the breadth of what we do. We've got the roadmap project. We're actually soft launching that today. We've got a Voices program and a survey that's going on. And over the summer, we're going to be launching some work with providers. So you can see our action plan there. But Benita and Takemia, I'm going to hand it to you over here so it doesn't scream at us.
Hi, I'm Benita. I am the Healthy Families Family Resource Specialist at the UpCenter and also the co-chair for BMHEAA. We're excited for this, kind of one of the first fruits of 2.5 years of work that we've done. This is something that we continue to be passionate about despite everything that is going on. We're really excited about the work that we are starting and able to continue. And we thank you so much for showing up and being here. This is when we talk about creating a village and being the village and doing the work, this is what we are talking about, that all of you are vital to the work that we're doing. And when you make that first step and just kind of educating, coming together, you really make a difference. And so we're really excited. Thank you all for showing up.
Good morning, everyone. Benita's the talker. I'm just gonna say good morning and I thank you and I appreciate everyone for showing up, even you guys on Zoom. Sorry if you can't hear, but we're gonna get that fixed for you. But thank you everybody for coming, showing up, and we really appreciate everything and everybody. NSU, thank you guys, the dancers, thank you. Thank you, thank you, thank you, everyone.
I'd like to introduce Teresita, Hammond, and Deborah Carlos. And I think you're going to talk a little bit about Deb, and are you guys going to talk as co-chairs first for the conference? Okay, Deb and Sherry will talk first.
Good morning. That's all I got. That's all I got. I'm not a public speaker. Good morning.
Good morning, everyone. And I just want to reiterate what they said. Thank you all for coming. It's going to be an honor and to see and hear and speak from every one of you. I'm really excited to see what this event has to hold and what information you guys are going to get. I love to hear the feedback. So let us know what you think at the end of it. But thank you all.
And I just wanted to take a minute to introduce our Sentara Health's Executive Director of Community Engagement, Sherry Norquist. This event was also sponsored by Sentara. We were able to help with the continuing nursing education credits and some other things, but I'm going to turn it over to Sherry just for some remarks.
Well, good morning, everyone. I am a public speaker, but there is a saying, and that saying is, it's a hard act to follow, which this is actually a very hard act to follow. So welcome on behalf of Sentara. If you could just take a minute and look around the room, because at the end of today, the work that we are doing requires this truly connective and collective impact. And so that is what I am hoping you walk away with today: new inspiration, new knowledge, and new friends. And so as we are thinking about this work, which is super complicated work, there's a problem to solve both for today, but keep in mind, the work that you're doing, the power you are creating, and the friendships you are making are actually saving generations. So let us not stand in the way of you all saving the world, and I hope you have an amazing day.
Thank you, everybody.
Dr. Albahan?
Thank you, Amy, for the invitation. I'm really honored to be here, Dr. Fulton. I'm honored to be on the NSU campus and really be in front of you with this incredible cause. I had prepared comments in my pocket, but following the eloquent introduction by Dr. Fulton, I decided to keep them in my pocket. However, I want to tell you a story. Patient comes in to labor and delivery, known to have a placenta accreta. That's when the placenta invades the wall of the uterus, typically in association with cesarean sections. significant rising in incidence over the past 10, 15 years. Had trouble getting some blood prepared for her because she has antibodies against a lot of blood products. Took about 4 hours to do that. Went to the operating room for the cesarean hysterectomy. Upon entry, about 1.5 liters of blood was already in the abdomen because the placenta had broken through the wall and started bleeding before with her contractions. Surgery involved 4 master surgeons, plus the trauma surgeon, the urology surgeon, but the patient went into DIC very quickly early on in the case and passed away 4 or 5 hours into the surgery. This happened within 6 miles from here and last evening. So I'm sharing this story with you to share how real your work is and how impactful the work that you do here today. We have a lot of barriers to really get equity in healthcare. We have a lot of access issues that need to be addressed. We have a lot of policies that need to be supported, maintained, and strengthened. And every organization that is represented today is holding hands to move forward towards that cause. I spent my whole career caring for women. That's my specialty, high-risk obstetrics. And I worked at Norfolk General for more than 30 years doing that. I'm honored and privileged to be introducing the meeting today. I know the value of what to do is impacting the family, impacting the community, and impacting generations. So thank you from the depth of my heart. And we are here to support, we're here to help. This has to have an educational aspect to it, this has to have training, this has to have policy change, this has to have community coming together to really solve this incredible problem. Thank you so much.
Before we get started, and as I mentioned, we have the privilege of being able to offer continuing nursing education credits for nurses who attended at no cost to you all. We were approved for 6.7 contact hours, and so before we can get started, I have to read a disclosure statement. Sentara Health has approved at Sentara Health is an approved provider of nursing continuing professional development by the Virginia Nurses Association, an accredited approver by the American Nurses Credentialing Center's Commission on Accreditation. 6.7 nursing contact hours are awarded for attendance at this program, completion of a pre-test and a post-test, and successful completion of a post-test with a score of 80% or higher. There are no relevant financial relationships with ineligible companies for individuals with the ability to control the content of this activity, and this program is being jointly provided by EVMS and ODU University. If you are a nurse and you are interested in credits, the pre-test and the post-test are over on that table. Please pick up the pre-test, put your name and your email address on it. After the program, you have to stay the entire time, pick up the post-test, take it, and then if you got an 80%, I will email you your continuing education certificate. And with that, I'm gonna go ahead and start the program.
Thank you. I think we're going to try to adjust the mic really quickly for the people online. I think they turned that one off, just so you know. Thanks for your patience, guys. This is Rasul, and he's saving the day.
Test 1, 2. You can hear me now. Test 1, 2, 3, 4.
Is that better?
Test 1, 2, 3, 4. Test 1, 2, 3, 4. Can anyone hear me? Test 1, 2, 3, 4. Somebody can check them on the chat.
They can hear me. Yes.
Can you guys still hear us? That's 1, 2, 3, 4. Your mic was on it first. Take it off perfect. Yep.
Good morning, everyone. My name is Destiny Flanagan, and I have the pleasure of introducing our first gathering session speaker for today. Today, we will be discussing creating safety for Black birthing families, and we will hear from Dr. Leah Porsche. Dr. Leah Porsche is a board-certified maternal fetal medicine specialist and assistant professor at Baylor College of Medicine and Eastern Virginia Medical School. She is a leader in high-risk pregnancy care, pioneering telemedicine services to enhance patient access and satisfaction. Dr. Porsche has developed protocols for the identification and management of placenta accreta spectrum and twin anemia polycythemia sequence, aka TAPS, ensuring safer deliveries for complex cases. A dedicated educator and mentor, she has held leadership roles in residency and fellowship training programs, shaping the next generation of obstetricians. She has presented nationally and regionally on racial disparities in maternal health and contributed to key publications in ultrasound and high-risk obstetrics. Dr. Porsche remains committed to advancing maternal fetal medicine through clinical innovation, research, and collaboration with referring providers to improve patient outcomes. And without further ado, the next voice that you will hear is Dr. Leah Porsche.
Wow, that was an intro. Thank you so much. I'm so excited to be here. I'm so honored. I'm humbled to be here. The work that we are gathered to do is so vitally important, and I always feel a weight whenever I am speaking because I had an hour. I don't know if I need to adjust that timing. Someone let me know. But that's not nearly enough time. Each slide in my presentation could be a full day of conversation. So my goal is not to be exhaustive. It is to give a brief overview of the importance of what we're doing with some information, and then highlight things that have been done, and then kind of propel us into the day that we came prepared to have. I'm not sure where my presentation is. Aha, there it is. All right, so, oh, that didn't show up as it was supposed to. It's okay, it's all right. It was a really cool kind of shadowed effect, but we're gonna go with it. All right, yep, that's me. You might be wondering how we got here. This is me with my delivery of my youngest, who is now 4. 13 hours earlier, I was taking my last pregnant bathroom selfie, okay? And I was excited about meeting my little one. What you don't see in this picture is that in the bathtub that's behind me, for days and weeks before, there were tears, there was anguish, because I was happy to be having this baby, but I was also terrified. Why were you terrified, Dr. Porsche? You asked me. Well, let me show you. 1 month earlier, there was Dr. Shanice Williams, a chief pediatric resident in Indiana, passed away shortly after her delivery due to complications of severe preeclampsia. Now, when I looked at her, I saw myself. I was accomplished, and I was having a baby. I was going to the hospital where I trained and where I worked, and none of that would save me if something were to happen. So I was excited, but I was terrified. And what does an educated woman do when she's terrified? She starts to plan. And so I made a birth plan. I knew that I had low blood pressure during pregnancy. I knew that I retained fluids. So I said, I don't want routine IV fluids. I don't want, hello, oh, hot mic. I said, I don't want, the sodium load that comes with that because I don't want to have hypertension later. I don't want anesthesia to drop my blood pressure with my epidural because I don't want to be run to the back because my diastolic is already 45. And then I wanted IM pit postpartum so that I didn't get, 1.5 liters of fluid that I personally didn't need. So you can see them honoring my wishes, giving me my IM pit after baby was on my chest. But I'm highly educated in this particular field. I knew exactly what to ask for myself. And so for women who don't know, we are the ones that have to be protecting them in that way. So my objectives, like we discussed, to discuss the different disparities that occur in Black maternal health outcomes, touch on some of the reasons for those disparities. That is a long and deep and wide conversation. Talk about some of the strategies that we've implemented and that we can implement to address these disparities, and then how can we empower the individual? All right, so newsflash, not really. Black maternal health outcomes lag in nearly all categories. Maternal mortality, and this, like Dr. Abu Hamid mentioned this morning, it includes maternal death within 1 year of a pregnancy, regardless of the location of that pregnancy or the duration of that pregnancy. So full-term delivery, miscarriage, ectopic pregnancy, all of those things matter. Early is within 42 days, late is 43 days to 1 year, and is reported as deaths per 100,000 live births. So this is a graphical representation of maternal mortality by race. The purple line is non-Hispanic Black women. And you can see that we are far above most categories, only exceeded by American Indian and Alaska Natives. This trend has also increased over the last few years, which is abysmal in a developed country. But the disparity has remained constant. This is just a different representation for people who digest information differently. And this is by year from 2018 to 2023. You can see, of course, the highest bars are Black maternal mortality. With the timing of maternal mortality, we have during pregnancy is 25%, but then the late postpartum deaths are the second most common. The causes for maternal mortality, and so for all comers, mental health is one of the front runners, and that includes mental health conditions and substance abuse. Cardiovascular, other conditions, cardiovascular with cardiomyopathy and other conditions, including hypertension, infection, hemorrhage, and embolism. And for Black women, one of the leading causes in this reporting time frame was infection. You got to think about COVID was during this time frame of reporting as well. All right, so this is a study. It's not a new study, but it's a relevant study. And I will probably present this study anytime I talk about this topic. So this was, I think, a very well done analysis of some of this data that shows that in this particular population, the prevalence of these conditions, preeclampsia, eclampsia, abruption, previa, postpartum hemorrhage, was not significantly increased in their Black population, but the case fatality, your likelihood of dying from those conditions, was wildly increased. So for, sorry, I think I'm talking too fast. I'm just trying to get through it all. So for our people who are not statistics girlies, okay, when you look at this column, the confidence interval, if it crosses 1, so everything on the left side, the left confidence interval, so it's not a significant difference, right? But on the right side, where we see how many women die for each case, it's very significant. And so we know that statistically, this is an actual difference between these two. So we may not be at an increased risk of, or increased rate of having preeclampsia, but we're 2.7 times more likely to die from it. We may not be at an increased rate of having postpartum hemorrhage, but we're 3.3 times more likely to die from it. And so this, I think, is just an amazing, if you can figure out what it means, this is an amazing summation of what we're up against. All right, preterm birth. So that's birth before 37 weeks. Extreme preterm birth is before 28 weeks. So again, busy slide, but this was a study that they did looking at adjusted relative risk for preterm birth by race, ethnicity, and where you were born. So were you Black, white, Asian, Hispanic? Were you born in the US or out of the US? And you see our outlier far to the right. Who do you think that is? That is US born, non-Hispanic Black women. Okay, so this is for all preterm birth. And this, this trend holds and is actually more pronounced for extreme prematurity. So what does that mean? The consequences of preterm birth, you can have cerebral palsy, hearing loss, vision impairment, respiratory issues, behavioral mental health conditions. So these are, it is not, if you survive the preterm birth, then it is not without long-term consequences. But you also get to wear a little bow tie while you have your feeding tube and oxygen in. Low birth weight and small for gestational age, also increased risk in Black women. For low birth weight, nearly twice as likely to have a low birth weight infant than their white counterparts. And having a baby who's small for how far along you are can result in hypertension, diabetes, metabolic syndrome, obesity. All of these things can occur later in life. So this is a burden that the baby then carries with them. Cesarean deliveries are increased rate in Black women. The overall cesarean delivery rate in this reporting period was 32%, 36.6% in Black women. And this is just a breakdown comparing the national average to Virginia, and Virginia really reflects the national average as well. All right, so we see that in many categories, Black women really have a disproportionately poor outcomes. But what underlies these disparities? So I tried to break it down between patient, provider, and system. A lot of these things are interwoven, and you can't always isolate each thing, but I'll try for simplicity's sake. For the patient, you can have pre-existing medical conditions, allostatic load or weathering, sociocultural perspectives on healthcare and illness. So what do they believe about healthcare in themselves? With pre-existing conditions, hypertension, almost 60% of Black women have hypertension. I was surprised by that. I was like, oh, it's a lot. It often develops earlier in life, and for any duration of chronic hypertension, Black women are more likely to have end organ damage. So you're more likely to have vascular disease, you're more likely to have renal disease for the same amount of time that someone else may have had chronic hypertension. Same with diabetes. Almost 19% of Black Americans over the age of 20 have diabetes. And again, we're sicker with diabetes, 50% more likely to develop retinopathy or end-stage renal disease. And the problem is the awareness of these conditions may vary. How many of us have had a patient who comes in at 12 weeks and their first blood pressure in the office during their pregnancy is 157/95? And you're like, ma'am, you told me you don't have any medical problems. She's like, I don't. And so, and then you do a glucose test and it's 212. And you're like, ma'am, you told me that you don't have any medical problems. She's like, I don't. It's like, well, actually, come to find you do. So awareness of these conditions, it varies. And if you're not aware that you have it, then you can't be actively addressing it. And so that's one of the things that can make Black women more likely to have complications during pregnancy. Obesity. Now I know that obesity is a hot button topic. There are a lot of information about whether it's the best way to stratify people regarding risk. There are people who can be heavier that are very, very healthy, and people who are teeny tiny who are very unhealthy. But we do know that there at least is an association between BMI and pregnancy outcomes. Women who are heavier have a higher risk of growth restriction and macrosomic fetuses, higher risk of hypertensive complications, higher risk of gestational diabetes, and higher risk of labor dystocia. So for Black women to have a higher rate of obesity, it is associated with those poorer pregnancy outcomes. All right, now what about this allostatic load and weathering? So weathering is whenever chronic exposure to certain social and economic disadvantage leads to biological aging, particularly in marginalized populations. And you can actually measure this by looking at the telomeres, those little red caps on the end of your chromosomes. And so the older you get, the smaller your telomeres get. And so Black women, on average, are 7 years older from a biological perspective than their white age-matched counterparts. And so that is not just kind of a social construct or I'm aging fast. Like, this is actually something that we see on a molecular level. And one of the examples that I like the best, that gives it a really clear image of what is weathering. People see our American presidents before and after their presidency. So this is Obama, our forever president, in the 8-year period where he was the leader of the free world. And you can see on his face and in his hair the stress that he carried. But this is a real and kind of tangible example of what weathering can do. Now, the next picture I'm going to show is actually like a biological specimen. So if you're squeamish, then you can close your eyes. I imagine most people who are in here are not, but if you are. So this is just a specimen showing a healthy new heart on the right. I think this was during a transplant situation. And then you can see the old stressed cardiomyopathy heart on the left side. So again, just another physical representation of that stress actually does physically affect our bodies. What about sociocultural perspectives, attitudes towards healthcare based on your personal experience or the shared experience of your community? Now, if you are getting advice from your aunties and grandparents that lived through the time of the Tuskegee syphilis experiment, then yeah, you're not going to trust a government or a healthcare system that allowed people to languish and die with syphilis when they could have been treated. That is not an unreasonable response to what happened. If you are reading about and hearing stories about Black women who were operated on without anesthesia to develop gynecologic procedures, you are not going to necessarily have just a blanketed trust for the people who are offering you healthcare. That is not an unreasonable response to the history that we've lived, but it now affects the way that people engage and interact with the healthcare system. All right, so we're going to kind of switch to providers. We know there's a lot of talk about bias. Conscious bias are biases that you know that you hold, right? The gentlemen in these pictures, gentlemen is a kind word to use. In these pictures, they had biases, and those biases directly affected the things that they did, the systems that they created, and the actions that they took. But sometimes bias is not quite so ominous, right? So when you look at this picture, I want you don't have to say anything. I want you to look at this picture and see, who do you think would be the best at helping you fix your computer? Don't say anything, don't say it. All right, now look at this one. Who do you think would be the best at helping you with your math homework? Who do you think would be the fastest? If everybody was in a race, who would win? Right? So I think everybody, can you just raise your hand and say, I have biases? Right? Everybody has biases. Sometimes they are relatively benign, but what about, okay, say that you're a provider and that somebody comes into your office and who do you think would be the most honest about how much pain they're having? Who would you be the least likely to believe if they said that something had been going on for 4 years? So, bias can be very in your face, bias can be relatively benign, and bias can be more indolent, and it can affect how you treat your patients. So this is moving into unconscious or implicit bias. These are the things that we don't know that we believe that still affect our behavior. So this was a study that was done reviewing 37 other studies. And 31 of those studies showed across variety of disciplines, across levels of training, that there persisted pro-white or light-skinned bias and anti-Black, anti-minority bias. 6 of those studies also showed that higher implicit bias was associated with actually difference in the outcomes in the care that providers gave. They also looked at studies looking at kind of the real world patient-provider interactions. And in 7 of those studies, they found that providers that had a stronger score for implicit bias demonstrated poorer patient-provider communication. So what about communication? I love this little bit. My patient, nothing my doctor says makes any sense. Doctor, nothing my patient says makes any sense. And so we kind of meet at an impasse. Now, if you think about it, providers, we have a whole separate language that we learn in medical school, and it helps us to communicate very effectively with each other. But when it comes to communicating with our patients, it doesn't translate. And then think about if you are in a provider situation and you're asking your patient, say I'm a white male physician and my patient is a Black woman. Say, how long have your symptoms been going on? Oh man, doc, they've been going on for a minute. Is a minute a long time? Is a minute a little bit of time? And so that person might not even register to ask that question, where we all kind of know it's been going on for a while, and then we ask, but how long though? So we would be able to make the appropriate follow-up question. But so these are subtle ways in which cultural communication can be a barrier. And this was just more of a perception study. African Americans, Hispanics, Asians were more likely to believe that they would receive better medical care if they are in a different racial group. And they felt that they were treated unfairly based on their race. 40% of women in this study reported communication problems. Having hypertension or diabetes was associated with a higher level of reluctance to ask questions. So the people who were the most complicated were less likely to ask questions. And this is abysmal. This is terrible. And this is what this one got me. Black women that were more educated reported more communication problems with their provider. And I have thoughts about why this could be, because we expect a certain level of education, interaction, questioning. If someone has a lower expectation than we do, then we're like, oh, this is going to be a problem. But I thought that was an incredible finding of this study. All right, so social determinants of health. Again, we could spend a day on each one of these. Education and access to quality education. Do you have schools that are near you that are accessible, that are either free or affordable? How much money do you make? Are you in a steady job? Are you educated sufficiently to hold the job that's going to meet the needs of the current economy? How are you connected socially? Do you have support? Are you isolated? Do you have family and friends that can help you whenever things are difficult? Where do you live? Is your environment safe? Is it an environment where you can actually rest, or are you even more stressed at home than you are in other places? And then, of course, access to healthcare. Do you have insurance? Do you not have insurance? Do you have a clinic that's close by? Is that clinic a quality clinic? Is that hospital a hospital that can actually meet the needs that you have? Placenta accreta with a large blood bank, and all of these things make a big difference in the quality of healthcare that you receive and your outcomes. This is just a graphical representation of the percent of uncovered patients, or uninsured patients, excuse me, before and after Medicaid expansion. And so you can see that the red is before, the blue is, this is before and after the expansion, but in states that accepted the expansion and states that did not. So in red are the states that accepted the expansion. They have a much lower rate of uninsured patients. In the blue are the states that did not accept the Medicaid expansion, and they have a much higher rate of uninsured patients. So, of course, the system and what they provide to the people makes a big difference in access. All right, so what strategies are in place to address these gaps? What have we tried to do to make these things better? Bias trainings, protocols and bundles, doula care, and maternal mortality reviews. So implicit bias training, who has done implicit bias training? Most hospital systems and organizations now require these on an annual basis to some degree. I think there's a lot of agreement about the necessity of implicit bias training. There has been some documentation that these modules can improve self-awareness about implicit biases. I came across a study in a police population that showed that after their training, their awareness about their implicit bias was improved. But over time, that awareness waned. And so you may become aware at one point, but how long does it take to potentiate and go away? So there are definitely challenges with persistence of awareness and behavioral changes. And there were many studies where they were trying to develop different ways to assess or accurately assess someone's implicit bias, which you can imagine is incredibly difficult if it's something that's unconscious and you're not aware of. So a lot more studies need to be done in order for us to be able to push forward with efficient implicit bias training. All right, protocols, checklists, and bundles. Why is there this cute little pilot here on this slide? Two reasons. One, the healthcare industry has borrowed a lot of protocols, a lot of systems, a lot of safety systems from the aviation industry. Your pilot that flies you around does not have to remember by themselves what to do if one of the engine fails. There is a book with protocols and they go through it. They learned it, but they're not relying on their memory in that situation. So a lot of these systems have been borrowed from the aviation industry. So we have risk assessment tools, ways to place patients into high or low risk categories. Our medical records have alert algorithms. So when a patient's blood pressure drops too low for too long, now we have a flag to say, hey, this person needs to have some additional attention. There are safety bundles like AIM. We put out a hemorrhage package, decreasing C-section, hypertension, things that you can put in place in a systematic way that apply to every patient every time that help to decrease patients slipping through the cracks because you're relying on the provider to make that decision each time. Simulation saves lives. Shoulder dystocia, postpartum hemorrhage, mass casualty, a lot of things, these things have helped to improve outcomes so that you're not practicing it for the first time when you see it with a patient. And of course, data collecting and reporting, we want to make sure we know exactly what's going on so we know where to focus our efforts. Now, the second reason I put this cute little boy on the slide is that not only is it my representation of the aviation industry, but he is actually the youngest Black pilot in the United States. Gabriel Carruthers. This is him whenever he was 5, but he got his pilot's license when he was 17. And that was about 2 or 3 years ago. So I came across and was like, I have to share this. This is so wonderful. So good job, buddy. All right, maternal mortality reviews. So what maternal mortality reviews are, they are groups that review all the maternal mortalities in an area, usually by state. They gather data, determine causes of death, identify if those deaths were preventable, and they can create recommendations for action. So if you can't optimize what you don't measure, and you can't measure what you don't monitor. And so this is a way that we monitor the information from maternal mortality to determine which ones are preventable and which ones aren't. And unfortunately, many of the reviews find that 60 to 80% of the maternal mortalities that happen are preventable if we had addressed it at a certain early enough in the process. So kind of a plug for the current department at Baylor. Our chair, since we knew that maternal mental health was so high on the list, we now have a dedicated maternal perinatal psychiatry and psychology department. So these two, so Dr. Evans is our psychiatrist, Dr. Osei is our PhD psychologist, and they offer care just to our pregnant patients from our hospital system. So we have somebody who is familiar with psychiatric meds. You don't have the patient that comes to you that whoever just yanked them off all their meds and they're floridly psychotic in your office and you're trying to figure out what to do. We have someone who knows how to manage these patients. And then for patients who either don't need or don't want medication or need adjunctive support, we have a psychologist who can do counseling, talk therapy, group therapy with these patients as appropriate. And it's been very, very well received, and the patients have really enjoyed it. Doula care. So doulas are support people who are trained to support moms during pregnancy, during delivery, and postpartum. This study looked at a group of high-risk mothers. I think this was in the UK, the high-risk mothers, and they did a qualitative study to see how did the doulas impact their care. They reported that they were helping them to overcome stress and anxiety, develop self-esteem and self-efficacy. They helped them to utilize services more efficiently and become locally connected. So we know that doulas help to reduce C-section rates, improve breastfeeding rates, reduce postpartum anxiety and depression, often offering culturally competent care in ways that you don't have to translate to that person. They help to advocate and empower patients. They increase maternal engagement and ultimately reduce healthcare costs. As we know, money talks, right? All right, so how do we now amplify the collective and individual voice? We're coming to the end, don't worry. Advocacy, storytelling, community building, and empowerment. So advocacy is the active process of supporting a cause. And my daughter, while I was doing my slide, she was like, "Mom, what's advocacy?" And I said, you know what? I think my lay interpretation is it's a way to be the voice for those who may or may not otherwise be heard, and to be able to speak and help them get their causes to the people in power. She also could not understand why people in power wouldn't help everybody. I'm telling you, if kids ran the world, it would likely be much better. But it was a wonderful conversation that we were able to have. So there's self-advocacy, so you advocating for yourself on a one-to-one situation. Individual advocacy can be someone advocating for an individual or a small group of people. And then system advocacy, which is the larger scale legislation, getting laws passed that will really affect the larger community. So I'm sure everybody is aware of Momnibus. There are, at the national level and on the state levels, this is a collection of bills that are put in place with the intention of improving access to care, documentation, data collection, insurance coverage, all sorts of things. And very recently, much of the Virginia Momnibus was able to go through. Some of them were amended and rejected, but we will celebrate the things that made it. Okay, so storytelling. Storytelling is prevalent in many cultures and societies, but it is definitely centered in the African diaspora and the African tradition. Storytelling has many, many purposes. It is transmission of history. It is admonition. It is the sharing of morals and values of the community. It is a way to warn people of things that have happened in the past. So it is definitely a way that is ingrained in our culture to share information. Encouraging Black women to share stories is one of the ways that we can elevate our voices. I think one of the main things that it does is it decreases isolation. And if you feel that you are not alone, I think you're more likely to speak. If you know that you're not the only person that has hypertension, if you know that you're not the only person that's struggling this bad with your diabetes, you're more likely to speak to your provider and you're not going to be silenced through isolation. This was a documentary that was produced on Hulu, and this was the story of one Black father and the loss of his wife postpartum due to a pulmonary embolism. And we also highlighted the stories of other Black fathers, so they were telling their story and sharing information. Storytelling can reduce fear, it can transfer information, can raise culturally sensitive awareness, it can help adjust expectations, and it's effective for educational intervention. And this was seen in a review of studies that had to do with storytelling with regards to pregnancy. It can be used as an intervention with traumatic brain injury for self-identity reconstruction and a means to process race-based trauma. Again, this is just where storytelling meets advocacy, where telling the stories to those in power can help to convince of the necessity. Community building, so including not just the moms, but including the birthing partners, often the fathers. These are two organizations that help specifically Black fathers. They educate them about support in pregnancy, delivery, and postpartum so that they can really be actively engaged in the process and be their partner's advocate in a very intentional way. I searched Black Maternal Health Summit. So things like what we're doing today are happening everywhere, and they need to happen everywhere. And I was so encouraged to see the breadth of what's going on, because we need to create community and we need to have these discussions and encourage each other in this way. Podcasting, Black Maternal Podcast. This was just the first part of the Google search. Women are sharing their stories. They are inviting others to share their stories as well. And you can just see utilization of podcasts has increased over the last few years. And I would be remiss if I didn't mention social media. So social media, where more people get their news than probably should, right? TikTok, YouTube, Instagram, all of these things are where people are going to get information. 74% of users are 18 to 44, and over half of them are female. So we have a captive audience if we can get these voices and the correct information in front of them. And my personal protocol, this is something that I didn't get this from a study, this is just what I do with my patients. I educate them. You'd be surprised how many people don't know what preeclampsia is. I'm like, I'm gonna put you on aspirin to help prevent preeclampsia. I'm like, do you know what preeclampsia is? I've heard of it. So educating them about what's going on with their body, what are they at risk for, what are they diagnosed with? Validating their concerns and fears, validating them. No matter how silly it feels, validate what they say. My baby is not moving. She knows her baby better than anybody else. It's living inside of her, okay? I'm in pain. I can't tell you you're not in pain. Believe them, validate them. And you don't have to, you can reassure, you can do whatever is clinically appropriate, but don't make them feel like what they're saying is ridiculous. And then encourage questions. Create an environment where questions are expected and encouraged. Patients, you wouldn't believe how many times I've asked, do you have any questions? No. 2 minutes later, any questions? No.
That was the majority in the bucket, probably.
Mom, mute your Zoom.
I want to know where's that one at? I'm pretty good.
You would be surprised by the third time that you ask the question, that is when they say, oh yeah, by the way, I've been wondering. And so create a situation.
I know whose it is.
You create a situation where questions are encouraged. That is ideal. So as we begin the day, be sobered, be encouraged, be inspired. And I want to tell you, be recharged. Please take a moment. If the workers get tired,
Cha-cha.
and so please recharge. Find a sunny spot. Find a nice wallpaper for your phone. Whatever you can do to find joy, do that. Rest. Rest is resistance. You need time to recharge yourself. This is heavy, heavy work. And if we do not rest, we cannot continue. And again, find joy wherever it can be found. Thank you guys so much.
Thank you guys so much as they work their way up here. I just want to remind the people who are with us virtually, please keep muted at all times unless you're directly asking a question during Q&A period. Thank you so much. I'm going to let DoVeanna go ahead or take over now.
Good morning, everyone. So my name is Devin Winston, and I'm going to be your moderator for this session. And I am truly, truly thrilled to be here today as we kick off Black Maternal Health Week. So since time is of the essence, let's jump right into this important session titled, What's Going On with Black Birthing Mamas Dying? So before we start, I want to start with a quick story. And this is my story. So back in 2019, me and my husband were super excited to give birth to our first child. I was a very healthy mama, went to every single doctor's appointment, no pre-existing conditions, gestational diabetes, hypertension, nothing like that. So we went in to a local hospital to give birth to my son, and we had an on-call doctor. So she comes into our room, she doesn't introduce herself, and she says, you've been laboring for quite some time. At the time, I had been at the hospital for probably about 5 hours. She said, you and your husband should consider a C-section. So my husband looked at her, and he's like, well, is something going on with her? Is something going on with the baby? She's like, well, no, but she is the furthest along, and it's other people in labor, she's the furthest along. So my husband was like, no, we're not interested in a C-section. So she was like, well, I'll give you guys some time to think about it. So she leaves out of our room, comes back in maybe about 45 minutes later. And she goes, so have y'all thought about a C-section? And we were like, no, again, is something going on? She was like, well, now that I look at the monitor, she's like, your temperature is 99.1 and you are showing signs of an infection. Okay, all right. So again, me and my husband are still like, no, we're not interested in a C-section. Is it something else we can do? My husband was like, can she try to push? Can she, get on her knees on the bed and let gravity, help the baby come out? She said, oh no, gravity is a myth. Okay. So, at this point, I'm in tears because I'm like, I don't need a C-section. There's nothing wrong with my baby. What's going on? And she's like, well, it's just a 45-minute process. It's going to be really quick. She said, I promise you everything's going to be good. So again, my husband's like, yeah, no, we don't need a C-section. So she tells her staff, just go ahead and prep the OR. So about maybe 30 minutes later, I'm on my way to have a C-section, again, like in tears, because I'm like, we don't need a C-section. It's nothing wrong with me or my baby. So I have the C-section, and they push me into recovery, and I'm like shaking, like uncontrollably. So the anesthesiologist grabbed my hand and he said, you did a really great job, mama. And he looked at the OBGYN and was like, she's freezing. She's freezing. So the OBGYN, she comes over, she lifts up the covers, she pressed on my stomach and look up. Like, my husband said, as soon as she pressed my stomach, blood just came out everywhere. So at this point, they're like, we need stat blood, blah, blah, blah. Like, my room is like filled with a whole bunch of people. And I'm like, what's going on? Where is my son? I haven't even seen him yet. I don't know how he looks. Is he fine? Is he okay? Where is my baby? So they tried to give me an IV. My veins were too flat, so they had to call in a PIC team. So 5 bags of blood they gave me, and the OBGYN said to my husband, we're gonna have to give her a hysterectomy or she's gonna die because we cannot stop the bleeding. So my husband's just like, okay, I don't know what to do, like, what's going on? So one of the charge nurses at the time was like, well, hold on, can we call interventional radiology? So they called down to interventional radiology. One of the doctors came up. He said, we're gonna try a uterine artery embolization on her. Let's see if that's gonna work. So, of course, this particular doctor actually went over the risk of this procedure, informed consent, something that I didn't receive when they talked to me about the C-section. Told me the risk, told my husband the risk of what will happen, during this urinary artery embolization, and that was that. So my story doesn't end that way, though. I found out I was pregnant again in 2021 with my daughter. And of course, I was scared because I was like, I cannot have this baby in the hospital. Like, what do we do? And, my spirit kept telling me that she was not going to be born it was a girl. My first one was a boy. She was not going to be born in the hospital, but I continued to go to the doctor's appointments. I continued to do everything I needed to do just in case I needed to have a hospital birth. I had a birthing plan, so I said, this time is going to be done right. Like, I'm going to be in control this time, because again, I felt patient autonomy was ripped from me and my husband. And, we had this trauma that we had been living with. So, the Wednesday before my daughter was born, I, go to my appointment, I have my birthing plan and I'm showing the doctors and they're like, oh, well, we can't do that because you may have to have another C-section. Oh, we can't do that. Oh, we have to give you this medication because you may have to have another C-section. So the only thing I kept hearing was, you may have to have another C-section. That means you guys are going to try to give me another C-section when I didn't need the first one. So that Wednesday was my last doctor's appointment before my due date, which was February 7th. February 4th, that Friday, I actually found a midwife that was willing to do a home birth for me, despite everything that she saw in my record. So I hired her on the 4th, and I actually had my daughter at home, a natural unmedicated water birth on February 7th, an 8-pound, 14-ounce, healthy baby girl. So that birth was so liberating for me, but it told me a lot of things. You're not a C-section once you have one C-section, especially when you didn't need the first one. Secondly, it is so important to understand what conformed consent is. You telling me I need a C-section, but not really why, and what's the risk of the C-section. And a lot of times you're gonna hear things like, oh, well, a lot of times that happens to people because of certain social determinants of health. Me and my husband were both highly educated, upper middle class. We don't fit that criteria that a lot of the physicians like to say. They just didn't want to hear what me or my husband had to say or wanted for our birth. But, so that's my story. my storytelling. And again, I'm so excited to be here to join in this movement to continue to break barriers and empower change for better health outcomes for mothers like myself and infants. So since all of you guys know my business now, we're family. So family, let's go ahead and get started and getting to introduce these amazing, amazing speakers. So first we have Ashley Nelson, who is a biology professor here at Norfolk State University. We have Maura Offer, a former US Navy officer, who's also a current professor here at Norfolk State University. And we have Leslie Cuffey, a dedicated doula with nearly 20 years of experience in maternal health. So each of these individuals bring a wealth of knowledge and experience to our conversation today. So without further ado, I'm excited to introduce our first speaker, Maura Offer.
Thank you so much, Dee. She is one of my closest friends in the entire world, and hearing her story all these months ago just even motivated me more for my research and everything that culminated that. So my name is Moira Offord. I am a biology professor as well, just like Professor Nelson here at Norfolk State University. I'm a physiologist and a biophysicist by trade. And what does that mean? Are you a nerd? Yes, I am a nerd and proud of it. But more importantly, I am even more important about sharing a wealth of knowledge and educating the youth and the students of our student body of pre-meds and nursing students that I teach here. It's important not just to know how the body works, but to know it in a disease state and how you can advocate for yourself. And my students who are all in the crowd, I see you guys, don't worry, I saw you come in. They know more than anything. When I teach them something about the body, I'm like, okay, so what happens when it goes wrong? And how should you know the signs to advocate for yourself, advocate for your patient, and advocate for those around you? And that's how I teach everything. And what I want to start off this talk with is to take us down a road of the history of obstetrics and gynecology, the pathologies that plague maternal mortality today and that Black women are predisposed to. And the following panelists will go into statistics as well as a call to action on what we can do to advocate. But part of me is advocating is educating. So the knowledge I give you here will equip you throughout your endeavors. So for whether you're expecting or you know someone expecting or you just want to become an OBGYN one day, it is important to know these things so you can go and equip to help your patients. So first, I want to highlight this diagram that we have here. His name is Chidebere Ibe. He's a Harvard medical student, and he noticed while in school that there were not a lot of anatomical pictures that featured him or people that looked like him with darker skin tones. Because as we know, pathologies present differently based off darker skin tones and hues. So he actually drew this and created this by hand. And so, and pretty much for that, he has a whole wealth of knowledge and resources for that so that you can see these, not just so you can have the representation of this is what it looks like, and I have an image of a pregnant woman in my hospital, but also you can learn, the future doctors and nurses can study these to see what it looks like for different pathologies. So I want to open up with a quote, you know, as the Reverend Martin Luther King Jr. said, of all forms of inequality, injustice in health is the most shocking and the most inhumane. So it's a matter of going towards equitable healthcare. So as we know, Black women are predisposed at a 5-time exponential increase of maternal mortality and morbidity. And unfortunately, as we spoke before in the previous presentation, about 80% of these cases are preventable by just anything from protocols that need to be put in place. And some of these comorbidities that we have seen are postpartum hemorrhaging, which is identified as a blood loss of greater than 500 milliliters through vaginal delivery or 1,000 milliliters a liter through cesarean section. Pregnancy-induced hypertension, also known as gestational hypertension, which we'll get into, and then preeclampsia. So we're going to go through these pathologies, not so that you understand, but also that you have that knowledge too, and so that we can prevent more of these in the future. But first, let's take a row back in history. Back in 1846, Dr. James Marion Sims, who is known as the father of obstetrics and gynecology today, he is known for perfecting his procedure of the vesicovaginal fistulae. It's a surgical procedure to perfect that, to fix that. So if you see this diagram right here, there is the urinary bladder and then the female's vaginal wall. And what happens is necrosis of tissue, which has an increased risk factor for women such as that are early births. And back then, due to slavery, Black women were giving birth at earlier rates, on average 3 years earlier than their white female counterparts. Things like that could cause wear and tear and necrosis and death of tissue, which would cause an opening in this canal, allowing urine and waste products to seep through the vaginal wall, causing infection, and then could have an increased risk of further complications. So he knew that Black women were predisposed to this because at the time they were slaves. So he exploited that and took 11 slaves, Black women, without their consent, and practiced for 4 years to perfect the vesicovaginal fistulae without anesthesia. And the reason why it was without anesthesia is a racial bias that does seep into nowadays as well too. You see that people with darker skin tones are deemed to not be able to feel as much pain or no pain at all. And because of that, he was able to pretty much say that by his justification, we don't need anesthesia for these patients. It's not necessary for the cost. So he would perform these, and as you see this image that was redrawn in front of an audience of a few doctors, and they would perform the procedure. It would be invigorating and painful. And then what would happen is she obviously was in terrible pain, so the other male doctors would hold her down until they got sick and tired. Well, not sick and tired. They couldn't stand hearing her cries and screams. It was just too much for them, so they would leave. But she still needs to be held down, right? So the other Black female slaves were forced to hold each other down as they took turns getting inflicted on this pain of this procedure. So because of that, pretty much in between postoperatively, he would treat these patients with morphine. And once treating them with morphine, that would kind of make them more compliant to go in between each surgeries. He did that until he perfected the procedure in 1849, and then was able to pretty much present it to the masses, to medical schools, and also to deliver the actual perfected procedure to white females using anesthesia. And I bring this up because it's important to know where we came from. One, that obstetrics and gynecology, some of these surgical procedures wouldn't even be here today if it wasn't for the sacrifice of Black women, unwilling sacrifice of Black women, and to see how we can improve today and advocate for our people. So now hurry up. So now let's get into the pathology. So we have preeclampsia versus gestational hypertension. So gestational hypertension is diagnosed after 20 weeks gestation of a heart rate greater than 140 milligrams per mercury over 90. So, and this is a diagram you have from the Yale New Haven Health guidelines showing the different varying blood pressures. And this is important. You should be able to know your body, and even if before you go to the hospital, you could get a blood pressure monitor literally from Amazon for cheap. And you just check your blood pressure every day so that when you go to the clinic and you feel like something's wrong, you can run that test. They're both hypertensive issues, preeclampsia and gestational hypertension. What makes them different is the presence of proteinuria. So proteinuria is, if you see a normal kidney filters out the waste products, ammonia, and any waste that's not needed anymore in the body, but certain things that are in your blood, such as albumin, stays in your body. So when it comes to that, because albumin resides in your body, you're not supposed to see it in your urine. But with a patient undergoing possible kidney failure, that is that proteinuria, albuminuria. These albumin particulates are present in your urine. You can run it from a urinalysis. So these combined are symptomologies of pretty much preeclampsia. So this is the symptoms, but from previous research, possible pathologies and the genesis of why has to do with abnormal placentation. So normally, a pregnant patient, those placental cells will invaginate through the endometrium and the myometrium. So you see this normal pregnancy right here, and basically reform in the spiral arteries. That's called trophoblastic invasion. But with a patient with preeclampsia, as you see, the invagination doesn't go all the way down efficiently. So that's abnormal trophoblastic invasion, abnormal placentation, which could cause abnormal bleeding. And because there's not enough invagination, that means that there's poor perfusion, more blood to get to the fetus. And so that's why the heart rate goes up. So unfortunately, we ran out of time. So the biggest thing about this is with severe preeclampsia, I also want to point out that it's elevated heart rate if it doesn't go untreated. The ultimate treatment for this is delivery. To this day, we still don't know the pathogenesis as to why. You can pretty much advocate for yourself with this. HELP syndrome, which is hemolysis, elevated liver enzymes, and low platelet count is the key thing for severe preeclampsia, and eclampsia is seizures. And let me give this to my colleague.
Great, thank you. All right, hello everyone. So I'm Professor Ashley Nelson. I'm a biology professor here at Norfolk State. I'm a medical scientist by trade, so another nerd coming at you today. I concentrated in microbiology in my master's program, but I'm also really into medical statistics. So I'm going to be sharing with you some Virginia-specific statistics about birthing as it pertains to Black maternal health and Black maternal health outcomes. I'm not going to go super in depth. I'm going to try and kind of give you the Spark Notes version, but I will be around if you do have any questions later. So first thing I do want to go over is the average cost of a vaginal birth versus a cesarean birth in the state. When we talk about a vaginal birth, I do want to clarify what a standard vaginal birth is. So this is a birth taking place between 37 to 42 weeks gestation in the state. This is also birth happening in a woman that is under the age of 35. So once you're at 35, this is what we consider to be a geriatric pregnancy, which probably sounds crazy. You're not even getting Social Security, you're not retired, but 35 is when you're like old lady pregnancy. So below that is what is considered standard vaginal birth. And we're also talking about births where there's not any complications like any hypertension, diabetes, preeclampsia, bleeding problems, anything of that nature. If you look at the prices on this chart, we are in the Eastern region, and you can see it's about $12,000 to have a standard vaginal birth, whereas a cesarean section hypes you up to almost $20,000. So there's a huge cost differential at that. On top of this as well, there was an Economic Research Bureau research study that was done in 2020. This found out that Black women are 25% more likely to have an unnecessary cesarean section than white women. So on top of already being higher risk for some of these birthing comorbidities that we're seeing, we're also seeing these unnecessary C-sections. And as I have said, and my colleagues have heard me say before, C-section is a major surgery. So you're not going to Claire's to get your ears pierced, you're having surgery. And as we know, surgery comes with, you know, it's the truth though. I mean, they advertise it like, oh, it's gonna take 45 minutes, you'll be fine, little scar, like nothing to it. But what comes with it is with any surgery, there's a risk of infection, risk of wound dehiscence, which is your wound separating, and risk of death. And unfortunately, those are not being told upfront. So let me keep on going through here and kind of expedite. So these graphs here are just talking about some of these demographics regarding birth. I do want to focus on the percentage of Medicaid births, which I will talk about now. So the reason why Medicaid births are significant is because Medicaid is obviously going to be one of the largest buyers or payer outs of births in the state of Virginia. Medicaid is of course going to be covering low income to no income mothers and families, as well as Medicaid. You're usually going to see these same people being covered, also qualifying for programs like Head Start and WIC. So not only are we seeing this birthing coverage, but we're also seeing those outcomes with those children once they're being born. In the state of Virginia, we did see the trigger law with the new administration in place. So many people were looking at losing that Medicaid coverage. With losing that coverage, you look at the risk of births going into a danger zone. So you're looking at that loss of healthy births. This slide here, I won't get too much into it, but as we heard in the previous presentation, even though money is sometimes the problem, so we see these outcomes with women who are in lower socioeconomic states, it's not always the issue. Serena Williams, highly decorated Olympian athlete, as much money as she has, as much education and standing in society as she has, when she went to go have her birth, she almost died. So the advocacy part is still there no matter how much money we make, how much education we have. It seems that no matter how much we speak up and what we say, it's never enough. So how do we fix that? These are some of the initiatives in Virginia specifically. The biggest one is investing in doula Medicaid benefits, where Medicaid, which is again one of the largest payers of births, not only in the state, but in the nation, is able to cover some of those doula benefits. We see that doulas are not only providing that healthcare towards women during and after the birthing phase, but it's also helping to lower that healthcare cost. And so without further ado, I'm going to pass it off to Leslie Cuffey.
I'm Leslie Cuffey. I've been a doula in the area for nearly 20 years. The only women that I know that have died in childbirth, educated Black women. I was Dee's doula, and what's going on with Black birthing moms dying? Systemic, all the systemics. We just heard about the slavery, and we're being taught by the same institutions. Thank you.
Thank you so much, Leslie. And I just want to end it with the biggest thing I want to say is to be that change that is needed. And a call to action is to focus on and educate yourself and educate those around you and have the resources that you need. And that's the importance of this Black Maternal Health Panel as it is. So these are the resources that we have. And for those that are interested, we have a sign-in sheet. We are more than willing to send you our PowerPoint with the data, with the information, and with some of these signups, such as Dads to Doulas course that was presented before, and then the Just for Dads blog that there is pretty much for those dads that are participating in childbirth and assessing their story so they can help and learn. Black Maternal Health Week that we had advertised, Chitty Berry, eBay's actual Instagram. And so thank you so much, everyone.
Good morning. You guys are receiving some handouts that we'll be using during this session. I'm Tanyata Green. I'm the Maternity Behavior Health Care Coordinator with Sentara Health Plans. I've worked at Sentara Health for the last 11 years, and women's health is my passion. Welcome to Talking the Talk, advocating for empowered Black birth. Dr. Leah Porsche, our first speaker, she already laid a foundation for us, educating us on advocacy. I have the pleasure of introducing to you two dynamic women in advocacy, Ms. Lakeisha Ferguson and Ms. Benita Thompson. Lakeisha Ferguson, she has her master's in nursing. She's a registered nurse, certified in maternal newborn nursing, and a certified childbirth educator. Lakeisha is a dedicated postpartum nurse with nearly 11 years of experience in women's and children's health. She's passionate about empowering women. She strives to to ensure that every mother feels seen, heard, and supported throughout their childhood journey. And we also have Ms. Benita Thompson. Benita Thompson is the Black Maternal Health Equity Alliance, Action Alliance co-chairperson. She's been the Healthy Families Resource Specialist with the UpCenter Healthy Families Program since 2022. She's a graduate of Virginia Commonwealth University, where she received her Bachelor of Science in psychology with a minor in African American Studies. With over 15 years of experience serving youth and families in multiple systems, Benita is passionate about serving the Hampton Roads area, the area where she was born and raised. Sorry, this is the area where she was born and raised, and with doing advocacy and collaboration. Without further ado, let me introduce and welcome our speakers of the hour, Ms. Benita Thompson and Lakeisha Ferguson.
Well, thank you guys all for joining us. I'm really happy to be able to talk to you all about this. I am not a speaker by trade. I am a nurse. But I do thank you all. I am so passionate about this. Working with moms for the last 11 years has just been such a wonderful experience. I've gotten to help moms go through labor. Oh, thank you. I've gotten to help them, just learn about being a mom, being a family. And that is just so important to me. I think the thing that really stuck out to me, why advocacy is so important to me is, I've helped all these women with birth. And then when my best friends got pregnant, I wasn't able to be at their births because my best friend lives 5 hours away, and things like that. And then to hear them talk about their birth trauma, about what happened during their births, and me, who's been doing this for so long, I wasn't able to help them during that time. But, we talk about it. We, talk about the birth trauma that they've experienced. And so for me, I don't ever want anyone to feel like they weren't seen, they weren't heard. And when it's your people, my person who had that birth trauma, I have always said in my career, no one that looks like me, no Black, brown, any woman should ever feel like they haven't been advocated for. Who's your advocate? So advocacy is defined as public support for or recommendation for a particular cause or policy. So who's going to be your advocate when you're in that birthing room is such an important thing to think about. So you can have so many different people. But when you're choosing your birth team, choosing your birth team really does make a difference. So when you think about your birth, the birth that you want, what does that look like? I teach childbirth classes, so I always tell my class, I want you to have an idea of what your birth looks like. Because a lot of times, we don't know what we don't know. So a lot of times for me, education is the strongest foundation for knowing what you want advocated for. So I always tell my moms, you have to be the biggest advocate for you. And then when you are unable to advocate for yourself, those people that are standing in the room with you need to be able to advocate for you. So what does that mean? You need to have open communication. So talking with those people who are going to be standing in the room with you, what does your birth look like? Because if they don't know how to advocate for you. So having open, trusting communication. How do you assemble your birth team to feel empowered, present, or informed? I always tell my patients, it's not about who is present in the room, but what does their presence offer you? You need someone who you feel comfortable with, someone that will go toe to toe with those doctors, with that staff. Because as a staff member myself, I know what I think you would want, but I don't know you. I don't know the ins and outs. I don't know what makes you you. Those people standing in the room with you, they know you. You know you. So I think it's very important that when you pick those people, you have had that communication, you've had those talks. So some important people to think about when assembling your birth team, doulas. So they add an extra layer of support. They can be those people who are there to comfort you, to comfort your partner. They are there to talk up for you when you cannot speak for yourself. When we are using all this medical jargon to kind of talk to one another, and you're just like, I have no idea what they're talking about. That doula can be there. Your support person is going to be there to say, hey, this is what it means when they're saying these types of things. You could have parents, friends, your significant others, but the most important thing is that you feel safe with these people. Informed decision-making. I know we've talked a lot about that. So again, I always tell everyone, you don't know what you don't know. So that's why we want to make sure we're asking those questions. Trust your instincts. You know, when we're going through things, I always say, if my stomach don't feel right, it ain't right. So I'm always like, you know, I may not know everything, but I know deep down something is not right. And even if you don't know what that is, it's very important to speak up and say, hey, you know, everything seems to be going, I just have a gut feeling that something is wrong. Can you look at this? Can you look at that? Because for me as a provider, that tells me, okay, like, what am I missing? I have X, Y, and Z going on. The baby looks great, but there's something that this is telling this mom, this dad, that something is not right. When we're thinking about informed decision-making, I always tell everyone, use your brain. So what that means, when a doctor, nurse, anyone comes into the room and they need to sit down and explain to you what's going on. So our brain, what is the benefit of this procedure? Or what is the risk of this procedure? So I need to know when going into a procedure, what is going to happen if I do it? What are the risks associated with this happening? What are my alternatives? Is there something that I can do besides the procedure, a test that you are saying that I need? Information. Do I have all the information about this procedure? And then N, nothing. What is going to happen if I say no? What is going to happen if we do absolutely nothing? So when thinking about informed decision-making, we need to use our brain. Yeah. And then the biggest thing I really want to talk about when advocacy comes is the fear of the angry Black woman. So many of us have that fear in our day-to-day lives of what is the perception that everyone is having of me during my birthing experience. And I'm here to tell you, please do not fear this. One thing I do like to tell everyone, I am going to, as a provider, I am going to know you 1, 3, maybe 5 days tops. If you're afraid of something during your labor, during your birthing process, that is something that you have to live with for the rest of your life. So for you to think that I'm going to be mad at you for that 1 to 5 days that I see you versus something that you have to tell, your birth story. If you experience birth trauma, this is going to be a lifelong process for you. So do not fear being an angry Black woman. And one of the things I always like to say is it's not just with providers. When we are assembling that birth team, it could be your family. Because guess what? Everyone, again, wants to be present in your birth. But then you start setting boundaries about what is going to happen. Hey, Ma, or whoever it is, I actually just want this to be an intimate thing between me and my partner here in my room. And your family, oh no, girl, I was there for X, Y, and Z's birth. I want to be there for you too. And it's like, thanks, sis, but nah. So it is very important, again, when you're picking those people to advocate for you, they understand the boundaries that you set, and then they will help carry those out as well. Because another thing when it comes to boundaries and having this fear of being the angry Black woman is that when we have a fear that we are going to be perceived a certain way, we tend to get small. No, ma'am. When we are giving birth, I need you to stand tall and speak about what is happening in your life. Because again, this is your lifelong story. This is just a snippet of my day, a snippet of what's going on in my, being a provider. This is a lifelong thing for you. And then when we talk about emotional security will help a mom have a more positive birth outcome, because if I don't feel emotionally safe, I'm not going to ask questions. I am not going to question anything that is going on in my room. I am again going to shrink myself to feel small, to be small, because you all got it, you know what you're doing. When in reality, I now am going to have to harbor negative feelings about my birth because I shrunk myself. Emotional security can lead to better maternal outcomes. When we feel empowered, it gives us a sense of belonging. And in your birth, you need to belong. You need to feel like you matter.
All right, amen. So continue on this thought of advocacy. It's important to know that you're not alone in learning how to advocate for Black birth. There are several tools, and so that's what I'm going to talk about. There are several tools and resources available to help guide families, especially Black families, and those who are marginalized, on how to navigate birth and how to advocate, how to self-advocate and advocate for others. One of my favorite things I learned about, thanks to BMHEAA, is the Black Birthing Bill of Rights. So the Black Birthing Bill of Rights is something that was created by the National Association to Advance Black Birth, and they created several terms, or I'll say affirmations, that families can use in order to know what their rights are in the birthing process. This is talking about things: I have the right to an advocate, I have the right to say no, I have the right to feel like my gender is affirmed, I have the right to experience and joy during my pregnancy. Like literally, there's so many. Y'all will have the link to it. So some of you already have a snippet of the original Black Birthing Bill of Rights. They actually expanded it, so it's about 3 times as long, which is why y'all have the old version, because it's a lot different. But this is one of the things that we encourage everybody to use as a tool. And I mean everybody, because at any point in time, you all come in contact with somebody who is giving birth. And if you're in the Hampton Roads area, you're coming in contact with a person that is a Black person that is birthing. So it is important that you have it, make it available for yourself, review it with your families if you are supporting those who are giving birth, those Black families. And again, it's something that can be used for anybody, because we all have these rights. But we know that the history has told Black people, like she talked about, to shrink in fear of being angry if you self-advocate, or how we advocate is different, right? And it's important to know that how you advocate matters too, and that you have the right to assert yourself in the way that you feel you need to assert yourself, and that don't let society, history tell you otherwise. And so that's why I love it. It's one of our favorite tools. I'm over here about to click the TV. So if you scan this QR code, they'll take you directly to the website, to the full Black Birthing Bill of Rights. If you notice, the images that you have in your picture look a little different than images on here. They've made them more vibrant and again, more inclusive. This one says, like, you have the right to be believed. You have the right to know that your pain matters. You have the right to be held and supported by your village. And you have the right to be free of racism. So these are just a snippet of the 12 pages worth of Black Birthing Bill of Rights and images associated with them. And they go into detail about what each of those mean. And again, I encourage everyone to review them. Like, it's actually a beautiful thing, because it's thought-provoking, and it's also, they put a lot of intention into it to help us know, because it talks about our culture and how we talk and engage with one another in society, and it acknowledges that. So I think that's really important. That's like what the first thing to know is that the way that we interact in society is different, and it matters, and it has the right to dictate how you receive care and are treated in care, and that's okay. So that's one of the first things. The second thing my personal favorite, because I work for Healthy Families, which is a early childhood home visiting program, international early childhood home visiting program. I also was a person who participated in early childhood home visiting program, Healthy Families specifically. I am an advocate for it. I think it's one of the best resources available to our families because it's free. Okay. And depending on where you are, it's inclusive. There are 6 or 7 home visiting programs in Norfolk alone. We are not short. We are short on people. Like, we still have open availability, but realistically, we shouldn't. Again, it's a free service. These are professionals that are trained to work and educate families on early childhood. It helps reduce infant mortality rates. It's proven to help reduce infant mortality rates, maternal care, improve maternal health outcomes, and help encourage children overall health. So Healthy Families and other programs work from birth through the child started kindergarten. So this person will work with somebody individually that knows them, gets to know them, builds rapport with them, and is able to teach them skills to help improve their outcomes until their child goes through elementary school, where for all intents and purposes, they might not be seen. So having somebody that's weekly or monthly checking in on you, that mom, and able to build rapport and talk about what's going on in life. I loved it because I was pregnant during COVID. And I was pregnant during COVID after a significant infant loss. It was traumatic for me. And I didn't know what I was doing. I was not comfortable, I was not confident, and I didn't know how to navigate these systems because they shifted. We all know COVID shifted everything, and I mean everything. So having somebody who's checking in on me weekly, and it was through Zoom, they connected me to resources that were local. They made sure I had diapers on deck. I tell people all the time, I had diapers and I didn't have to buy diapers probably for like the first 6 months. They made sure I had knew about conferences and groups that were going on. Like, this is the work that they do. Like, and they're trained and they love to do it. I haven't met a home visitor that doesn't love their job. And if they do, they leave. They will leave. And that's like just a snippet of what they do. But our part of the program was it gave me a doula. It introduced me to a doula. We refer for doulas. We connect. We know the doulas that are available. We know the ones that is a part of the program, is to know what's going on in the community, because if y'all operate in Hampton Roads, you know there's a lot of services, but really difficult to navigate individually. So home visiting does that. We stay up to date. My role literally is to stay up to date with community resources, to know what's going on and connect families to it. I got Deb 2 times because of it. And it was a part of our program. I believe there's a couple of other entities that provide doula care, and if they don't, they show you how to navigate and help you refer. So that's one of the things that also is beneficial. And again, this is a proven support, and it's free because it's paid usually through either a grant or Medicaid or Department of Health, like it's paid for. And there are certain programs, some programs require income restrictions. Healthy Families and PAT don't. I know that CHIP does, but they also work with families 2 to 7 years old. Again, having somebody helping you navigate these systems through it. Imagine how many phases you go through from pregnancy, literally like the moment you get that positive pregnancy test, through your child's second year in elementary school. Like, having somebody that's helping you navigate those systems, and you can be honest with them, because they're not CPS. They're a mama, they are a teacher, they're just chilling with you. No judgment. Like, it's so freeing. And one of the things I tell people all the time when I tell people about home visiting and its benefits is that if it had not been for my home visitor, I wouldn't, I'm gonna cry about it a little bit. Oh no. I wouldn't have known I was dealing with postpartum depression. It was because of my home visit. I was stuck in COVID with a child struggling breastfeeding. And because of COVID, breastfeeding resources were very limited. Nobody wanted to, they did not want to meet with you, So having somebody check in with me, and she was like, so how are you doing? How are you feeling about baby? And I was like, I mean, it's cool. I remember saying, like, she's like, don't you just love him? And I was like, cute. And because of that, it triggered like, hey girl, so have you thought about therapy? And it was said in such a way where it wasn't like she's screening me and I didn't know I was being screened. And because I am a mental health advocate, it was nothing for me to say yes to therapy, but also like, she was very like persistent, because again, she's meeting with me weekly. She's checking in on me weekly, and she's able to say, hey, so maybe therapy could be beneficial. And they know, we are the UpCenter, so we have therapists and perinatal counselors right there. So being able to refer was also easier for us to do. But again, home visitors know how to navigate even those systems. They know they're checking in constantly because everybody is dealing with some type of mental health issues. And so you're kind of constantly referring to different programs and entities. So you kind of like, oh yeah, they got a wait list over here. So maybe we can refer over here. And they ask those questions to the providers without families having to navigate it themselves. So I could literally go on for days talking about early childhood home visiting, but I'm gonna pause on that. There are, I think the research that we give as a part of BMHEAA is to direct you to -9 to 5. -9 to 5 has a directory of all of the current home visiting programs and how to refer. And it's pretty straightforward. Literally, most of them just need you to refer by name and number. Don't give email, please don't give email. Name and number, and it's usually that easy to kind of initiate a referral. So if you contact any of them, it is available in all 7 cities. At least one program is available in all 7 cities, if not 2. So it's available, it's free. Some have wait lists, some don't. Norfolk, again, has 6 to 7 programs. They're not like you'll find somebody, I promise you. So please encourage families and be open to participating in a program because it is, again, one of the most informal services that families can have that is so intense if needed. So my next one, we already touched on it every time. We always gonna talk about doulas, okay? Because we have to. Doula care is just vital. I think one of the things, somebody else put a slide up to let you know that doulas are kind of like the nurses, the aide, slave, servant to the mom. And I think that's important to know that a doula is there to care for mamas. A doula is a trained professional who provides continuous physical, emotional, and informational support to their client before, during, and shortly after childbirth to help them achieve the healthiest, most satisfying experience possible. This is reported by Donna International, which is kind of like the big entity for doula care. Again, doulas will teach you about childbirth education, they teach you about comfort measures, they will connect you to other resources. Again, if they're the first point of contact for a family, they'll know what other things could be beneficial to a family, helping them navigate doctors, being able to talk about conversations such as like, hey, I don't feel comfortable with this doctor. And they might say, hey, change your doctor. And that could be really beneficial. That's empowering for a mom to know, I don't have to stick with somebody I'm not comfortable with. And I think we constantly feel like we do. And it's your birth. You do not have to stay with anybody that you're not comfortable with. Literally nobody. Because why would you? Like, how is that beneficial to you and your birth and your child if you're stressed and trying to appease somebody else's emotions or feelings or whatever else, their finances, like it just doesn't matter. So doulas are an advocate by nature. Most people that are going to this field are there because they just love to be there for other people. And that's what you really want. You want somebody that, again, is informal, that can be there to really show you how to move your body in comforting ways, showing you how to use different the comfort measures, but I wanted to say the actual like mechanical things, tangible things. I can't think of the word, but I was, because like the peanuts, but whatever. Yeah, like peanut balls, and then like things to rub your back, whatever. Anyways. But that's one of the things that doulas do. Our next panel is actually going to include doulas, so we're not going to go heavy on it, but know that it's a resource that's available, and we're thank goodness for the Omnibus Act for allowing that to be funded through Medicaid and insurance. Like, come on now, like I remember learning about doula care, and it was like $500 out of pocket, and of course that was minus inflation. And so now it's about $1,800 out of pocket. So imagine getting that for free up to 8 sessions, whereas that was something that you probably have 3. So it's really one of those things that like is a beautiful thing. And as they get included in different programs like our home visiting programs, you'll see that it's more accessible, that is more long-term. I think a couple of programs allow you to have a doula from the moment you find out you're pregnant through birth. That's amazing because you're not paying for it. So, and to have somebody that you're truly building rapport with, another person that is just there for you, it makes your experience even more beautiful and more meaningful and more impactful. And then another handout that you have is one of the things that the CDC has started was the Hear Her campaign. And again, this is a QR code that'll take you directly to how it addresses pregnant and postpartum moms and families. Basically, it's an advocacy tool, literally. So it's used to help you know that like your experiences matter, why they matter, and what language to use to advocate for yourself, verbatim. So like they literally have warning signs, so things you need to be aware of when it comes to feelings you might experience while pregnant or postpartum. And when we say postpartum, we have to make sure we make it clear. We're talking about up to a year postpartum. Mamas are at risk for a year. Most people think, oh, the first 3 months, it's fine. No, like if you have had a child within the past year, you are still at risk of presenting symptoms that could put you in danger and are related to that pregnancy. So make sure that you know the words to use. And so when you go into the doctor, you can say, I'm feeling this, and it's this level of intensity. And you know, like the words that they would use and that they're looking for, so that because we might go in and be really emotional. And so if you have somebody there that's there with you, you can maybe have them literally go down the checklist of what to say, why to say it, how long something has lasted, because you don't think about it. Like you really wouldn't know until somebody asks you, but if you kind of do it in advance, or you have somebody there that's able to know, like they're gonna ask these questions. So let's kind of review, this is what's happening. And then you can also have clarity of like, yeah, I need to seek help. So I think that's one of the things, the tools that we use. And again, one of those resources that we want everyone to kind of make available if you come in contact with those who are pregnant, because, and again, the QR code is easy. So bookmark it, save it for if you know somebody later. Everyone can use it. So Hear Her is not just about Black women. It is about everybody, everybody that's experiencing pregnancy and or postpartum care. So that's one of those resources that we also promote. I think that's it. Thank you.
Hey, Benita, do you guys have a little bit of time, actually, if you want to take a few questions?
I didn't know we were doing questions, but feel free. I didn't mean to laugh that loud. I'm sorry.
Are there any
Sorry.
questions here or in Zoom? You can take yourself off mute to ask the question.
Do we have any questions?
So hearing you speak, I started thinking about my baby sister. I'm about to cry. She hasn't had any postpartum care after her daughter. Her daughter's almost a year. So what would you say? Like, how can I encourage her to go and follow up and get the care that she needs?
I personally start with hearing her, because why are you not looking to go to a doctor? And like making it an open space. Like if I interact with a mom, I do assessments for families that come into home visiting. I've heard the gambit. If they've not received any prenatal care and they're 8 months pregnant, or they went to the doctor once and they were like, it's fine. Like that is not an uncommon experience. It's abnormal. Like it's something of concern, but it's not uncommon. But there's a reason for it. A lot of times it's lack of education or a fear. Usually those are the top two. So hearing that person and asking them like, why? Like it's your sister, y'all know each other. So ask her like, so what's the issue? Like I'm worried, because you should at least have one check-in with the doctor to know what's going on. But why are you not doing that? I think that's the first step, because until you know the why, then you can go down the rabbit hole of what. And then also like, hey, go to the doctor, like encouraging, like, no, it's like, it's just a doctor's appointment. They're gonna check your cervix. Girl, they just want to make sure you're healing. You know, you don't want.
I just sent her a message. I said, she said you need help. So I said, well, let me just ask. Thank you.
Any other ones? Yes, I like questions.
So mine's not actually a question, but it's a comment. It's a comment that piggybacks on what you said about the angry Black woman. Like that, I think was such a big, I'm so glad you mentioned that. Because one construct that I use, and this is kind of for providers, is that anger usually is fear turned outwards. A lot of times sadness can be fear turned inwards, but anger is fear turned outwards. And if somebody is angry, they're scared about something. And if you can retrain your brain to hear the fear that is being carried, because anger is a vector. It is strong, it is big, because you need that scared place needs something stronger to carry it. And so whenever you're if you're angry, like, hey, and I love the word concerned. I think doctors should use it. I think patients should use it. I am concerned about, and being able to script that. But I think that I'm so glad that you mentioned that, because like you said, it's one moment in time for me, for you, but it is a lifetime for that person. And the angry Black woman is a scared Black woman. And so I want us to try to change that framework, because that's what's actually going on.
Guys.
I just would like to say as a doula that when I stood up and said the only women that I know that had passed away were educated Black women, none of those women were my clients. None of them had doulas. And I love what you guys are doing. And I want to know, part of me being a private doula, I encourage you to get care elsewhere, leave. How do you go about that?
I am a straightforward person. I don't really sugarcoat much. That's why I like this role. I'm not gonna hold you. I'm not beholden to, we're not beholden to ethics, or I get to be very informal with the person. So I'm not a home visitor though, mind you. I check in with them. So I get the freedom, if I'm building rapport with you, to be very honest. Other people who are long-term, they might have to work towards that. It just depends on the goals, but I ask, what makes you uncomfortable about the doctor? We talk about how far along you are. I've stopped plenty of assessments to have the conversation. If they're uncomfortable with their doctor, so why are you staying with them? Is it that doctor? Is it that practice? What makes you uncomfortable? Like a recent mom I talked to, it was the customer service at that, which is actually common. Sometimes they don't want to talk to the front desk staff. That makes them deterred from wanting to pursue other care. That's important. That's an underrated issue that I've heard more than once, is that the customer care from the front desk is actually the bigger deterrent for our moms than the actual providers themselves. So that means, have you made a grievance? That means, have you looked at other providers? It's what's important to you. And I think, or we'll talk about, well, then maybe that's something you can talk about with your home visitor, see what your options are, because we know that every provider is not inherently going to take someone if you're 36 weeks pregnant. You might not get as many options, but some will still take you, but they're accepting, because at the end of the day, it's still care. Somebody has to deliver the baby. So that's not inherently something that we want to deter them from thinking. No, know that you have the right to your provider and to be comfortable when you're going to prenatal care, because what if that raises your blood pressure and now you're hypertensive? Come on now. We don't want these issues. And so I'm that, literally how I'm saying it now is how I say it to them. That's who I am as a person, as an advocate. So because I think you have to be honest. I think always asking the questions, trying to figure out where their point of view is coming from, is first steps, but also letting them, I love the fact that I get to empower my moms. I get to kind of just continuously girl, this is your birth. This is your experience, because people just don't always feel that way. They feel like this is a business exchange, and it's not. This is literally your life-giving experience. Nobody else gets to dictate that but you. So feel confident and comfortable doing that. And from the front desk staff to how comfortable you are standing up or sitting down or laying down, or all of it. Who's around you when you're giving birth? All of that matters, and it has to matter. And you have the right for it to matter. So that's where I start.
And I was just going to kind of say I work in the hospital, so I have a little more constraints. So for me is, if I have a mom and I'm all about vibes and I can tell that the vibe's off, I will just, can someone else go into the room? Can someone else, talk to this mom? Because she may not be comfortable with me, but she may be comfortable with someone else. So in the hospital, just getting other people to talk to the same person, they may have different, be easier to talk to.
Hi, I was thinking about in regards to behavioral health for postpartum. So I'm thinking about, sometimes with the insurance coverage, you have a limited amount of sessions that you may have for mental health. So I'm thinking about postpartum, are there more added? I know
we have some behavioral health persons already that focus specifically on postpartum issues, or the resources, if you've met your max, I hate to say that, of your sessions, that if you're having a postpartum issue, that you can find resources for that.
I think that's one of those things that is based on insurance. I haven't had that issue, Medicaid or private insurance, so I don't have personal experience with that. And a lot of the moms I work with do have Medicaid. Medicaid doesn't have that restriction because I think they mainly want to look for a diagnosis, if I'm not mistaken. But I think as advocates, then you kind of create an actual service plan. Like that's the therapist's job, is to create a service plan. So if you know you only have you can only do 12 sessions in a year, so maybe only meeting in monthly. And let's talk about postpartum Virginia and you attending their support groups. Let's talk about home visiting support. So somebody's checking in on you. Like that is what all of those things are in place for, which is also why we're here. Because again, that network is important, not just because of us being able to connect as professionals, but because the services are available, but we don't know them. So that wraparound support will look different based off of that need. If there's inherently something, there's gaps in there, they can only meet in monthly. So what can we have in place weekly? And do we have safety plan in place? Do we know the crisis team that's in place? The crisis numbers that exist, the text, what is it? 899, no, 988. Knowing what's available in between time, because not everybody's needs are even as in, for when it comes to postpartum depression. I wasn't suicidal. I just had flat affect, right? So I was just lacking emotion and was stressed. But some of our moms have more intense needs. And so maybe there's another diagnosis in there to support more of a reason for them to have more long-term care. That's kind of how the behavioral health system works. They want to see a justification for everything. So if you're increasing amount of visits, they want to see what's the diagnosis to support that and what's the inherent need to support that. So as a team, just knowing, like really being able to ask those questions and get in place, so.
I know, I come from the hospital side of things, so I know that we screen all of our moms right after delivery for postpartum depression. The hospital that I actually work at, we also have a postpartum support group. So I know at discharge, we always encourage our moms, it may not be right now, but just know this resource is always available to you. So we have I always tell my moms we have a postpartum support group. We have a mommy and me support group, because some moms will start with that mommy and me support group, build that community. And then, they realize, hey, they'll be sitting in support group, hey, I'm not as happy as all these other moms. Like something is going on. And luckily, our person who runs our support groups is a nurse practitioner. So she's actually had, I know some people are here that I work with, and she actually was meeting with a mom. She's our lactation consultant, who is also a nurse practitioner. And a mom came to her, told her, I'm having thoughts about harming myself, harming my baby. So she, in that moment, was able to get that mom down to the ER. She was able to get that mom the support she needed so that she could go on. And, because if that mom would have went home, would have said nothing, we could be grieving 2 lives right now. But she felt comfortable enough to speak to her, to let her know what was going on. And we are so thankful for that, because I know we want to build those communities, build that support, because if a mom does not feel supported, she is not going to come to us. So I know when I sit down with all my patients every shift and just talk to them like, hey, you're going home today. What does that look like for you? Do you have support? If you don't have support, these are the resources that our hospital can ask. And I always encourage my moms, if your nurses are not telling you their resources, ask, what resources do you have for me going home? Because I always tell my mom, this is not where our journey ends just because you had the baby. We want to continue to support you after you have the baby.
Thank you guys so much. We're going to give some instructions now about what happens next.